Hello, I'm Robert Purchase, an orthopedic surgeon here in San Francisco, California, with a specialty in shoulder surgery and sports medicine. But I take a fair amount of call in the emergency department, and I get to see a lot of trauma patients, and I get to treat a lot of fractures. Fracture care is a diverse topic and runs the gamut from the mundane, such as a cast or splint, to the unfamiliar. Unfortunately, the emergency department is a very challenging place to do patient education. This video is intended for fracture patients to review, so that they have the opportunity to visualize the proposed treatment options and ultimately add to their understanding of those options, and so that they can ask more informed questions and become a more direct participant in their health care. Having said that, I hope that you find this video informative, helpful, and in some way enjoyable. So there are a couple of ideas that one should understand about fracture care before we get too far into the discussion. The first is that there is no difference between a broken bone and a fractured bone. The words broken and fractured mean the same exact thing. Not all fractures are the same. In fact, each fracture has its own personality of sorts. Furthermore, not all patients are the same. As such, each fracture patient has unique functional goals and requirements. Due to the unique aspects of each fracture in the context of the individuals in which they occur, choosing the most appropriate treatment option can be a very complicated process, requiring someone skilled in that process to do it right. When a fracture can be treated non-operatively, this type of treatment represents the best balance between risk and benefit for the patient. Having said that, some fractures require surgery. Surgery is indicated when the surgeon anticipates a poor functional outcome with non-operative care, and the surgery can improve on that functional outcome with an acceptable level of risk to the patient. The other reason surgery may be indicated is to avoid the complications of non-operative care. For example, femur fractures will heal with non-operative care, yet we almost never treat them this way. The reason is that prolonged bed rest and traction causes other medical problems and so much deconditioning that it is impractical to do it. When hardware is implanted to fix a fracture, it begins a race between what will happen first, fracture healing or hardware breakage. In a repaired fracture, the stress that usually goes through the intact bone goes through the metal. This stresses the metal construct ever so slightly. If the bone never heals, the cumulative fatigue will eventually cause the metal to break. On the other hand, if the bone heals before that happens, the healed bone unloads the hardware and the hardware never breaks. Most of the activity limitations orthopedic surgeons place on their patients after fracture surgery is to limit that accumulated fatigue stress on the construct in an attempt to ensure that we win that race. Fortunately, we win more often than we lose. On the flip side, the longer you immobilize a joint, the greater the risk that stiffness will become a problem, especially with fractures treated with more invasive types of surgery. So the surgeon needs to balance those two opposing forces, limiting weight bearing and/or motion to protect the repair, but allowing weight bearing and/or motion to avoid stiffness, atrophy, and others. Unfortunately, some fractures do not heal. This is called a non-union. Unfortunately, some fractures heal but will result in persistent pain and dysfunction even when perfect care is delivered. These fractures tend to be high-energy injuries such as falls from ladders or motor vehicle accidents. Fortunately, non-unions and those types of fractures that result in persistent pain or dysfunction are relatively rare, and your orthopedic surgeon will inform you of the risk of non-union and/or persistent pain and dysfunction early in the evaluation process. Here are the treatment options, and I'm going to run through each of them now. Non-operative care for fractures generally means some period of immobilization in a splint or a cast. Generally speaking, it is the safest form of treatment in that the patient is not exposed to the risks of surgery such as infection, nerve vessel injury, etc. Unfortunately, not every patient and not every fracture is amenable to this kind of care. Percutaneous pinning involves moving the fracture into a better position and putting a pin or pins across it to hold it in the new improved position, all without making an incision. Because you are not making a big incision, there is not much scar formation. Since there is not much scar, there is a lower chance of stiffness with this kind of approach. External fixation, also known as X-fixes, is sort of like wearing a cast, just without the cast. This treatment option is the most outside of our normal experience and is the hardest one for most patients to visualize. So putting an external fixator on involves putting a set of pins on either side of the fracture. These pins go into the bone and stick out of the skin. The pins are connected to each other outside of the skin with a bar, rigidly holding or stabilizing the fracture. It's a relatively minimally invasive technique that can be used for both definitive care and to provide temporary stabilization in specific settings such as fractures with significant soft tissue injury or in patients with more serious, life-threatening injuries. Intermedullary rods are large metal rods that are placed within the middle of the bone. They are often secured or locked above and below the fracture site. They are often used for fractures in the shafts of bones. The metal rods tend to be large and strong, allowing patients to at least partially weight bear relatively early in the healing process. Therefore, you can hopefully decrease the deconditioning associated with prolonged bed rest or prolonged periods of non-use. Open reduction internal fixation, or OIF for short, refers to the placement of plates and screws through full traditional incisions, allowing complete dissections and visualization of the fracture sites. You can directly manipulate small pieces of bone and get them back in the right position. The final option is to replace the joint. Some fractures have a poor healing potential, and it results in a more reliable and better outcome to replace the joint, or more commonly, half of the joint. The most common scenario in which we use this technique is a common form of hip fracture, a femoral neck fracture. In this situation, the fracture also disrupts the blood supply to the fractured portion of the bone. Without blood flow, that bone won't survive and will never heal. Therefore, we will do half of a hip replacement. For similar reasons, some shoulder fractures are more appropriate to do a shoulder hemiarthroplasty. In very, very rare instances, joint replacements can be done for very specific kinds of elbow or knee fractures. Well, thank you for your interest. I hope that you found these comments helpful. Please remember that all comments on this site, including the comments contained within, are general in nature. They do not apply to any specific clinical scenario or any individual patient. The comments are meant to provide general background as an introduction to complex topics. The comments posted here are not meant as medical advice, nor should they be regarded as a substitute for examination, diagnosis, and medical care provided by a licensed and qualified health professional. All listeners are encouraged to see their personal physician regularly. All cases and clinical information presented represent examples of general themes, presentations, or issues. They do not represent a single case or the information of a particular patient. Your feedback and comments are encouraged. However, please do not post information that can identify any individual, including specific questions regarding medical care. Any such postings may be deleted. Thank you.